Hi, this is lesson number 2 for Bali, ILT. And we're just starting with a quote as always. And this quote says, "The birth of human life is, in reality, an expression of the rapture of powerful spiritual energies uniting. Therefore, birth giving is a fundamental expression of the sacred in life." Conversations with the goddess. Yeah, it's beautiful. So I'm just going to touch in on some things that I began on last week. Before we get to all the juicy stuff of pregnancy and love hormones and births and babies, we're going to look at what surrounds the world of maternity and to be able to build on that so that we know which paradigm we're actually functioning in. And I'm going to go back and mention some of the things that I mentioned before and just go in on them and round it off for you, because last week was a kind of a quickie. I'm also posting quite a few videos for you to look at. I'm hoping your internet's going to be okay. And let's see how it goes. So back again to technology and childbirth. And just talking about technology means we're looking mainly at surgical procedures. Part of the technology are surgical procedures and interventions. And it's actually well known. And Marsden Wagner from the World Health Organization had written a paper on this and has put this into a fact sheet that 20% of all births, no more, need surgical procedures. And the thing to remember this is that all surgical procedures carry risks, that it's just a fact. And this is one of the reasons why midwives are safer than doctors in low-risk situations, because midwives use far less unnecessary technology and therefore less interventions. And this is interesting because obstetricians are actually surgeons. They are the only surgeon in the medical profession that is not trained to be a surgeon specifically, but is an obstetrician and therefore does surgical work as in a C-section. And they do like to turn birth into a surgical procedure. I know this is general, and I know some absolutely divine obstetricians who abhor the idea that all births are medical. But the proof of this is that birthing women are treated as a surgical patient when they come into a hospital. And I've been to hospital births in many different countries, and the very first thing that happens in a hospital birth is that a woman is put on her back in a bed. You're sick, as in get on that bed where I have control over you. And that's really just a modified surgical table, really, and often with her legs up in stirrups. And if not up in stirrups, at least she's holding them up herself and lying there like a beetle on her back, basically. And for more than 25 years, we've actually known scientifically that this is the worst possible position for a woman to give birth in. Literally scientifically proven. 25 years we've been, having to deal with this terrible position for birth. And still it's being used. I was at a birth 2 days ago in a hospital. Guess what? On your back, because it's more comfortable for the physician to be able to see what he's doing, or she's doing in this case. We know that in this position the baby's head compresses the woman's main blood vessel, which is called the aorta. So the main blood flow that supplies the womb is suppressed and therefore reduces oxygen, because that's what the blood is, one of the things the blood is carrying to the baby. And the baby can become distressed due to this lack of oxygen. And we know that if a woman's in a vertical position, sitting, squatting, standing, and even hands and knees, which is really kind of a sitting position then tilted forward, there is more blood and oxygen flow to the baby, and the woman's bony pelvis opens more to let the baby out. We're going to talk a lot about this when we talk about birth and we look at pelvises. But it's so strange that this position, kind of a surgical position, is used in births worldwide in hospitals. And in Bali, you are going to see it too, that the midwives kind of find it easier, and the women birthing find it easier to just go and lie down. Um, this is something that Ivy will discuss with you, and it's something I think needs a bit of attention. So the modern technology is not all bad. There was a BBC News report the 15th, so last week, that in Ghana there's been a huge drop in maternal and newborn mortality. And why? It's just so simple. What is making a difference is that that women are receiving messages via their mobile phone. It's called the mobile midwife, and the midwives are not only it's kind of linked to when they check in a woman in. There's a link that goes through to her phone number and sends her messages about your appointment is coming up, or you have to come tomorrow, or your appointment is today. It also sends food about nutrition timed for that time of pregnancy, and things that they should be looking out for or being aware of in that time of pregnancy. And it's a really simple simple way of actually reaching women who don't often come to their prenatals, who don't come and see the midwife regularly, because it's a far walk, because it means a day off work, because it means waiting in queues, because it means leaving children at home, or finding care, or making children walk with them. I know this well from Africa. And I also know from Africa, in the 40 different countries I've worked in, that everybody has a mobile phone. Wow. And that's obviously a new thing. So modern technology is not all bad. Let's go back to the question of autonomy. What is autonomy? Midwives are autonomous professionals who provide primary maternity care. So this means that this should and it is in some countries, but not in many. It should be the first line of care that a woman comes across when she's pregnant. So she gives primary health care, like a family physician gives the primary care. If you've got something, you first go to your physician. He then will refer you to a specialist if that's necessary. And it's like if the family physician hears a heart murmur, or he thinks, okay, these headaches are not normal, he will, in the heart murmur case, he will send you to a specialist, a cardiologist. And this doesn't mean that the family physician is now the cardiologist's assistant and somehow less competent. It's just that it's a different expertise. And for certain expertises, the family physician will send through people to those specialists. And in the same token, a specialist obstetrician should not be giving orders to a midwife any more than that cardiologist should be giving orders to a family physician. They work together. The midwife may refer a woman to an obstetrician because of a complication. This doesn't make her the obstetrician's assistant. And the midwife and obstetrician need to collaborate and work together. The midwife is kind of the scanner and the guardian of natural pregnancy and labour. So, home or birth centre, that's often the discussion, as versus hospital. And many, many studies, I pulled them up one by one, and I've got them at the end of this PowerPoint. But studies show that there's no greater perennial risk for planned attended home births than for hospital births, and significantly fewer interventions. High quality US studies that show that there's no difference in perinatal mortality between and planned. I've really made a fuss about saying that it's planned, because planned means that this woman is low risk and therefore she can be planned home birth. And hospital births. And high quality Canadian studies have been confirming that there's no difference in rates of perennial deaths between planned home births and hospital births, with much lower rates of both interventions and adverse outcomes. Remember that in hospitals they look at short-term fixes, and then we sometimes see long-term adverse outcomes. A Dutch study of over 500,000 births shows no difference in perennial mortality rates or NICU admissions, so neonatal ICU admissions, between planned home births and hospital births. And then high quality UK German studies show no difference in perineal mortality risks and lower risks of both interventions and adverse outcomes, and it just goes on and on. So there's evidence very much of higher satisfaction among women choosing to deliver at home. So that the highest satisfaction rates worldwide, there have been studies done, are women who've planned a home birth and who birth at home. Highest satisfaction. It's something like 90% of these women, or 97% of these women, are very, very satisfied with that outcome. The least satisfied women were, unfortunately, the ones who planned a home birth and ended up with a surgical intervention, or having to go to hospital and ending up with many or various surgical interventions. And the next after that were women who ended up with a C-section when it wasn't a planned C-section. So high satisfaction amount for women choosing to deliver at home, and I would say in a birth center with their first-line midwife would probably fall under that same fact, same percentage. And then home and birth center births are proven to be more cost-effective. Now, why wouldn't that be interesting for the big medical industry? And I love this cartoon. He says here, sorry, officer, but my wife is in labor and I have to get her home. It's really great fun. I love the officer who's thinking, obviously you should be heading the other way. So birth or home, and either are for low risk mothers, and they provide this unrestricted access to birth companions of her choice, of the birthing mother's choice, the freedom to move around and to birth in any position they choose, and it involves less unnecessary interventions. Here is the low-risk C-section rate in various settings. Freestanding birth centers, 3.7 of those women ended up with a C-section. Low risk started in a birth center. Low risk starting at home and wanting a home birth with a nurse midwife, a certified nurse midwife or a certified professional midwife, 3% of those births ended up as C-sections. And then low risk hospital births attended by doctors, 22.9% of those births end up with a C-section. And then I'm not talking about all the other interventions, which cascade into all kinds of different situations, and some end in a C-section. So my conclusion, and the conclusion, is that a well-trained, well-equipped, autonomous midwife, autonomous meaning she makes her own decisions and she makes the plan, the protocols and the plans for her clients, together with her clients, is the best practitioner for a low-risk mother. Either home birth or freestanding birth center are the best places for low-risk women to birth their babies. It really is, I think, for you girls preaching to the converted perhaps by now, having spent some time with Ivy, but really it's good to just get that into your head. It's good to be able to have that conversation with somebody at a dinner table who says, what? You want to do a home birth? And off we go. So see you in the next lesson. Bye.